Prodromal symptoms in bipolar affective disorders, prodromal mania, and substance abuse. Thank you very much for giving me the opportunity. Also to our esteemed moderator for accepting the job. I'll be talking about prodromal symptoms in bipolar affective disorders, prodromal mania, and substance abuse. Prodromal as a term is a period of deviation in a person's life. It's not only used in the psychological framework. Before the bipolar diagnosis is made, they refer to the precursor symptoms. It's a window of precursors. There might be extensive symptoms. There might be not as extensive symptoms, so it's very difficult to suspect this as a diagnosis, but the transformation is thought to be more, and you're also aware that in SCH and prodromal SCH there might be a high verbal IQ, and there might be repeating depression, so that's an interesting finding. Subconscious thought disorders, strange ideas, judgment disorders can be quite differentiating for prodromal schizophrenia. For OKB, suicidality, communication problems, depressive DO, concentration and memory disorders, anergia, physical agitation, and various affective instability, psychotic mania prodrome can be quite differentiating. And the bipolar risk is at its highest in the subtype. If there is a mixed depression, then between the 14 and 17 years of age, it's very frequently seen that it's transformed into bipolar. After 22 years of age, the risk decreases. So, in the bipolar findings, 50% of the cases had prodromal symptoms. Anxiety, panic disorder, trauma, DAB, various emotional liabilities, somatic problems might be present. If psychotic symptoms also exist, then bipolar development can happen between 0.75 months to 3 months. For psychotic mania, prodrome duration is 20.4 months, on average is 1.8 to 7.3 years of prodrome period. In polar depression, if there is no sudden onset, if there is psychotic retardation, psychotic findings, catatonic features, amnesia, terminal insomnia, atypical depressive conditions, self-blame, non-reactive depressive mood, weight gain, somatic activities, lesser concentration and memory abilities, irritability, overconcentration, lack of response or over-response to SSRI, or worsening with SSRI might mean that bipolar risk is higher. A few studies show that children of bipolar parents might suffer from unipolar depression, SAB, AYAB, TSSB, AAB, DHB, CCOY, and cannabis use. When we look at the ordering of these findings in the premorbid periods, there is anxiety, minor depressive findings, extra sensitivity to stress, depressive episodes, and within 3 years, if there is bipolar development, then diagnosis is made accordingly. As per DAFI, if there is pro-inclination, there is a higher risk of bipolar development in adolescent, up to 80%. If there is bipolar history in the family, if there is OKB in the patient and other prodromal observations, then there might be psychotic mania. Prior to prodrome, there might be some premorbid findings. These are retrospective studies to behavior. Within the first 3 years of life, some behavioral problems might happen. In the preschool period, again, there might be extra sensitivity, various behavioral reactivities, elevated irritable episodes that continue more than a year. There might be also different energy levels of these children. In the school children, there might be a sad affect and mood. There might be depressive moods more than 1 hour a day. There might be unexplained episodes of happiness. Very swift behavioral changes might take place. There might be boldness, extra courage to speaking too fast. I will look at the prodromal findings. The literature suggests the following for classification. Various psychopathologies that cause dysfunctionality like asocialization, various depressive findings, and other cognitive findings. As per House et al., in 2011, we see mania, depression findings, cyclotonic conditions, anxiety findings, sleep disorder findings, psychotic findings, and obsessive compulsive OCD findings. I will look at the bipolar prodrome symptom interview and scale perspective. Here is the structure and items as per Coral 2014. There are 6 sub-classifications. The first one looks into mania, the second one into depression, the third one looks into the general symptom index. As per these scores, we can come up with a risk score. The most frequently used is the bipolar at risk, BAR criteria, developed by Bechtolf et al. Between the years 15 to 25, there is 22% risk of bipolar development within the 265 days as per BAR criteria. The patient is between 15 to 25, and there should be at least 1 tick out of the 3. Manic findings. I'm not going to go over them one by one. Cyclotonic features or conditions. Depression plus genetic inclination for bipolar. Let's look at the early phase inventory for bipolar disorders. This is the EPI bipolar criteria. Major criteria is genetic risk, cyclotonic features, subthreshold, hypomanic symptoms. Minor criteria group is changes in sleep and circadian rhythm, depressive disorder with specific features. Minor criteria group is substance use, misuse or dependence, diagnosis or suspected diagnosis of such problems. Here is a meta-analysis of 21 studies from 2016. The most frequently seen prodromal findings in later diagnosed bipolar disorders, sleep disorders, changes in energy levels, cognitive deformation, competitive thoughts, elevated energy, being too talkative, but of course at sub-threshold level. As per the results of 2 meta-analyses, the most frequently seen prodromal findings are increased energy level, irritability, DD lability, distractibility, increase in purpose-related behaviors, aphoria, there is also a relationship between eating disorders and prodromal mania. In anorexia nervosa, if if there is associated euphoria, increased or elevated energy and exercise findings, then there might be a higher risk of mania. In this group, antipsychotic use is or should be preferred rather than SSRI use. And we also know that if there is anorexia and bulimia nervosa, then there might be association between the two. For schizophrenia, the relationship between that and prodrome, the indicators are a bit different, whether there's a psychotic history in the family, premorbidity, autistic features, subpsychotic findings, longer or prolonged prodrome duration, more subthreshold positive findings, and passive association. When we look at the treatment, the first phase is psychotreatment. We need to consider the family situation. We need to inform the family and the child. The children need to be preserved at school, maintained at school. The express emotion need to be reduced. We need to alarm the family, but we also need to keep them hopeful. If there is bipolar history in the families can blame themselves. We need to tell that not all cases will result in bipolar. There is less medication used here. The best design is omega-3. Omega-3 is found to be effective in reducing the risk to mania. Omega-3 preparations in Turkey, the pH are actually lower. This is 7:1. This should be the level, so the dosage is important. There are two studies. The methodologies are not very good, but it results in improvement in prodromal findings. It also reduces the transmission rates. The lithium is found to be not efficient, but the methodology is said to be not as good. Ethiopian study at 300 to 600 milligrams for 12 weeks have proved to be lowering the subthreshold manic findings. If there is BAB depression prodromal findings in the family, quetiapine 150 to 300 milligrams, quetiapine XR 150 to 300 milligrams, plus ramatrigine, omega-3 high dose, and fluoxetine or olanzapine can be used. SSRIs should be avoided. If it's necessary, it can be used at low dosage. For schizophrenia, we sometimes use it, but there is the switch risk. If there is DHB, then psychostimulants could be used in preference for atomoxetine for anxiety disorders, and if there is BAB in the family and prodromal findings, bucipron, coitapine, and pregabalin can be used. My second topic is the combination of BAB and MKB. For adolescents, if there is bipolar, then that increases the risk of drug abuse 45 times. In a Danish study, it was found that 32% of bipolar cases were drug abusers. The reason is because MKB interferes with the prognosis of BAB and increases the risk of relapse. In some studies, we see that some mood disorders might further exacerbate the situation. Intoxication by other stimulants can be mixed up with hypomania or mania. If there is a fast cycle of bipolar disorder, it's very difficult to differentiate. However, these bipolar cases are more inclined towards substance abuse, particularly for cannabis. There is a relationship between cannabis and fast cycle. When we look at cocaine, triggered grandiosity is deemed to continue for a long time, and that might make it difficult to diagnose mania and differentiate between this and the mania. Bipolar cannabis might trigger a development of psychosis rather than bipolar disorder. And synthetic cannabinoids might trigger various mood disorder findings. If there is suicidality, then there is a higher risk of bipolar development as per the study. If there is drug abuse plus bipolar disorder, what do we do in psychopharmacology? Valproate can be used for bipolar adolescents, and it's found that it reduces the use of cannabis and cocaine and increases cognitive functions. In the early years, it was thought that lithium was not very efficient for adolescent drug users. However, recent studies have shown that it can be used. Our clinic findings are in conformity. Carbamazepine we think is not very efficient. However, lamotrigine and lithium can be used for bipolar drug users, for mania, for mood disorders and depression. For bipolar drug users, we prefer VPA. For some studies on children and adolescents, there are some incongruencies in the sense that during the manic period, lamotrigine plus topiramate are more effective than adults. They are effective in bipolar depression in adults. However, in children, this efficacy is even higher. We can also cite lamotrigine for cocaine and methamphetamine plus polar, VPA gabapentin for methamphetamine plus bipolar. For inhalant solvent plus bipolar, we can suggest use of lamotrigine, risperidone, carbamazepine, and buspirone. Lamotrigine is particularly usable for inhalant solvent plus BAB combination, and for MDMA, ecstasy, and BAB we can suggest olanzapine. These are of course findings or the opinions by authors, so should be taken with a pinch of salt. These are not certain facts but just opinions by the authors. For MDMA, ecstasy plus bipolar, we suggest olanzapine. It's effective for both drug abuse plus the bipolar. Lamotrigine can be used for cocaine, methamphetamine plus bipolar. Topiramate for AKMB, alcohol, cocaine, cannabis plus bipolar. Gabapentin, pregabalin can be used for alcohol and substance abuse plus bipolar anxiety disorders. However, for children, of course, we need to remind that gabapentin and the pregabalin can be abused. Therefore, these should be administered by the families. For bipolar drug abusers, aripiprazole, olanzapine, quetiapine, and risperidone can be used. Since conformity can be low, paliperidone on a single dose can be sedative and can be quite effective. For aripiprazole, we can suggest for it to be used for cocaine plus methamphetamine plus bipolar cases. From 2017 study, we see that 5 to 20 milligrams per day could be effective for bipolar and alcohol substance abuse combinations, as well as psychotic disorders. NAC can be used for cannabis plus methamphetamine, cocaine, and bipolar combined cases with depressive conditions. And we also know that azathioprine is not yet brought to Turkey. On the website it said that it's available, however it can't be found in pharmacies. This is all I have.